On behalf of my institution, the Medical School of the University of São Paulo, I'd like to thank a lot to the organizing committee. It's quite strange to be in Brazil with a section with only Brazilian people speaking and trying to speak in English to you all. I would like to apologize for my awful English. Okay, let's go ahead. If you look to the evolution of the total knee replacement along the history, we became from the very beginning from the interposition arthroplasty in the past, going to the resurface, and then to the most important two branches of arthroplasty nowadays, the cruciate retained and the posterior stabilized knee. We have a very strong evolution in the stabilized posterior knee in the last 20 to 30 years, especially with the insole bursting design. And many people are doing a lot of these procedures, and maybe this kind of design is one of the most used all over the world. But many people are doing the cruciate retaining, and if you look during the last 10 to 15 years, the cruciate retaining knee prosthesis is growing up, and many people are doing that. Let's talk a little bit, I know every one of you know about that, but talk a little bit about the function of the PCL. The PCL, as we know, is the most important posterior stabilizer of the knee, but it has any other functions, as tension in flexion, the generation of translational force during the flexion, the femoral rollback, the posteriorization of the contacted point between the femur and the tibial plateau. It increases the efficiency of the quadriceps, that's what is very important in an older person, especially with a replacement in his knee, and decrease the impact in the joint. Although it generates more tensions inside the joint, it decreases the impact in the joint. Why do I prefer a CR or a PS design? People that prefer the CR design has many explanations for this. Better stability, the rollback, the greater flexion that absorbs shears, best proprioception. The PS surgeons says that it facilitates the correction of the deformity, improves the fixation of the knee, greater congruence of the design, decrease the polyethylene stress for this reason, and that it's technically easier to do. But the main answer is because I train in doing this and because I prefer doing this, although we have many explanations for both sides. Let's talk a little bit about the literature before 2000. If you look before 2000, many papers were written about this matter, and they pointed different things for us. Let's talk a little bit about the kinematics. Some papers show that the kinematics are better for the cruciate retaining because it would preserve the natural anatomy of the knee. But some others say, especially some studies doing with fluoroscopy in vivo, that when you sacrifice the posterior cruciate ligament, the kinematics of the knee still is the same with most of the designs, especially with the posterior stabilized design. And that retaining the cruciate ligament, especially when we are working, I don't know if I have a laser point here. Is this yeah. If you go to a design like this, a flat-on-flat knee, I know there are still some flat-on-flat knees, but most people are not using flat-on-flat knees anymore. We have a paradoxal anterior rolling. And if the PCL is loose in this kind of design, you have where, especially in the anterior part of the polyethylene, that you show in the next slide a little bit better. If you go to the range of movement, if you look for sacrificing cruciate, stabilized posterior cruciate and cruciate retained, the range of movement is almost the same in this design. And there are some studies showing this, although there is a little tendency of a little bit more range of movement in the PS knee. As I said, if the PCL is tight, you have a very limitation of flexion, important limitation of flexion, and if it's loose, you may have a flexion instability, what may cause important wear in the anterior part of the polyethylene. Some other disadvantages of the CR knee. Technically, it's harder to do, and it may increase the wear, as I said. The PS design has some disadvantages also. You need to increase the release. It's a more invasive surgery, not too much, but a little bit more. You need to make the space for the cam. And some designs have diminished the movement, although the majority of them makes the movement better. This is a very traditional design about the wear and the overload in the surface, showing that the cruciate retain replacements puts a lot of load in the same area of the polyethylene. And the PS design that's a little bit more congruent has a distribution of this load a little bit better. But in fact, nowadays you have many designs of cruciate retaining prostheses that are very similar to the PS design in this aspect. So it's not a real argument to say that we are putting a lot of stress on the polyethylene nowadays. We had some other problems like the movement of the seesaw. We have different points. It may be worse because you'll be moving your femoral component or during the whole surface of the tibia, but it may be good because you are distributing the stress on this polyethylene area. And when you have a post, you will move the shear to a compression force. What's good sometimes, but maybe it can cause, maybe it could be a cause of loosening in the tibial component. It's just theoretical point of views about this. Talking about loosening, if there are many studies before 2000 showing that if you go to long periods of time, you have the same percentage of survival of both replacements, both the PS and the cruciate retained knee, with almost the same time of durability in this case. And many articles show this for us. And what about proprioception? That is one of the most important reasons for retaining a cruciate ligament. Some papers show that really, it's really important, and the proprioception is better in the cruciate retaining design. But there are some studies showing that there is no difference at all between PS and CR. Another point of view that's very important is about the degeneration of these structures, the anterior cruciate ligament and the posterior cruciate ligament. It's natural that in a person that's frequently is more than 60 years old, you have some kind of degeneration. The bone is a little bit degenerated, the cartilage is completely degenerated, the ligaments is also a little bit degenerated. And the anterior cruciate frequently is very, very degenerated. It's one of the reasons of the evolution of the osteoarthrosis. But the PCL, although you have some histological arguments to show that you have some degeneration in this structure, this degeneration is not so important. All of us that do replacements frequently find a very degenerative knee with a quite good posterior cruciate ligament. So it's a matter of discussion. Another consideration is the function of the posterior cruciate for the stair climbing. The posterior cruciate ligament helps in the strength of the quadriceps muscle. And when you lose the posterior cruciate ligament, you have some deficiency in this function. So it's more difficult, and sometimes you need to do anterior tilt of your body to climb one or two steps in a stair. But some other studies say that there is absolutely no difference if you have a PS model or a CR model. So the studies are very controversial in all these point of views. You have arguments for both sides. What about the deformity correction? If you have a deformity that's bigger than 15 degrees, naturally you know that's more difficult sometimes to release all the tissues and put the knee in the right alignment. And so in the situations, you need to resect the posterior cruciate ligament. But how many knees are more than 15 degrees of deformity? Not so much. Some very severe valgus cases or some very severe varus cases. But even in this situation, the survival of these replacements are quite good. What you should consider is that the cruciate itself is not always able to give all the stability the knee needs, especially if you have some important insufficiency or some instability of peripheral ligaments. And we know that we have some elongation in some ligaments in the medial or lateral side, and some contraction, some retraction of the sides in the varus and valgus knees. So we need to be thinking about all the problems we have the knee when you are doing the surgery to decide if I'm going to keep the posterior cruciate ligament or not. This is a revision that was done by Scuderi and Pagnano in 2001, and most of these articles, and more than these articles, are mentioned in this revision. They make a brief review of the evolution of the replacements in the last 20 years, especially in the side of the posterior stabilized knee, and many revision different topics. And as a final conclusion of this revision in 2001, they say, it's better to do a PS knee than a CR knee. But you can find arguments for both sides even in this review. But it's the position of these two authors that we know that the information and where they trained in their life and when they worked with are people that were doing PS knee during all the time. Are the creators of the PS knee. Let's move for the more recent literature. In fact, is a presentation of our group, our institution, in the same Congress, Brazilian Orthopedic Congress, in 2004, 10 years ago, comparing some different aspects in the PS and the CR knees. And we didn't find any difference in both knees, except in the intraoperatory and immediate postoperatory time, a little bit more bleeding, but not too much. It was significant. And let me talk about the significance in the statistics. What does it really mean for the patient? Absolutely nothing. But unless it has a very severe anemia and has a very old patient with many comorbidities, it may be important. But what does it mean as a difference? But it's highly different in the statistics because the numbers are different, too much different. So you need to take care about the statistics. And if the statistics does not do any real sense in the clinical practice, maybe it means nothing for us. Okay. This is a study looking for another point that's very important, the mid-flexion laxity. During the whole time of the knee replacements, especially more than 10 years ago, we were thinking about the extension gap and the flexion gap, the extension gap and the flexion gap. Naturally, they are very important. But you have the mid-flexion gap. And what happens in this situation? And you have a lot of mid-flexion laxity. And there are some studies more recently showing that the posterior stabilized total knee replacement, the mid-flexion laxity is a little bit more important than the cruciate retaining, because you can keep the tension during the whole movement with the posterior cruciate ligament, what does not happen with a can and a post. This other study saying what's the whole of the cruciate ligament, they have three groups of patients, and the strongest part of this paper is the number of the replacements they study, more than 3,000. In some of these replacements, they keep the cruciate. In part of them, they just recessed it a little bit, especially in the tibial side, to get a little bit more loose. And some other patients, a lot of liberations in the posterior cruciate ligament was the group of excised, PCL, they say. And after many years, you can see here, 14 years to 16 years, the final result is almost the same, with small difference. But anyway, the CR design was better than the PS design. Not the PS design, but the excised PCL, naturally, the knee that does not have a PCL. This other study, it's an anatomic study with only 5 knees, was a great limitation. But anyway, it makes a TEC scan membrane that can check for the impact forces in the surface of the knee. And they see that we have more concentration of strength in the cruciate retain than the PS knee. But is it bad or good? Naturally, it moves to an idea that you have more stress on this polyethylene. But maybe it's much more near of the natural function of the knee. This is the reason why you have more stress in this area, in this kind of knee. Let's go to some revisions and some meta-analysis more recently. This is a meta-analysis from the Cochrane Foundation of 2005. And in this meta-analysis, you find that the PS knee has a little bit more range of movement, 8 degrees. 8 degrees is very important for someone that has only 7 degrees of flexion. But if you have 115, 120, it's not too much, it's not so important. But they found any other difference looking two articles that have the conditions to be studied. In a more recent revision, 2012, they will find that there is a better range of movement, not so big as they found some years ago, and no other difference also in 9 articles they could study. In 2013, recently, another meta-analysis showing that the PSR has a little bit more range of movement, no other difference in 12 articles. And they mentioned the decision to use one design versus the other should rest with the surgeon preference and comfort with a particular design. And in 2004, so very recent here, you find another meta-analysis showing that there is no difference in function, pain, complications, and survivalship of both designs. A little bit of more range of movement. In conclusion, there are no significant clinical differences in both designs. Why I do CR or PS knee? And I go back to one of my first slides. Because I prefer doing this way, because I'm trained doing this way. I myself do 95% of cruciate retained knees and only 5% of PS knees. Only very difficult situations of correction of deformity, very tension, PCL, very degenerative knee, but most of the knees I keep the cruciate. That is a little bit less invasive surgery than the posterior stabilized design. Thank you very much for your kind attention.